Good afternoon, everyone. This is another series in the COVID IGHS series. Today we have an absolutely magnificent speaker on a very, very interesting topic, which is an update on COVID testing. Dr. Michael Busch is not only a faculty at UCSF, but he has been in charge of the Pacific Blood Centers for a while. We have been collaborating together in Chaga's work in the past in Brazil and elsewhere in blood banks. He's one of the scientists I respect the most for his encyclopedic wisdom and knowledge about everything related to blood and biomarkers. So it's a real privilege to have Dr. Mike Busch with us today. And I give him the floor. The dynamic is that after he makes his presentations, both Colin and I will be moderating the Q&A. And you are able to send your questions through the Q&A icon. So we look forward for a very dynamic and productive talk. Mike, you have the floor. Thank you so much.
Sure, my pleasure, Jaime. Yeah, so I wanted to give a few slides just of overview background that many of you may be aware of, but a little more relevance to the virus and the kinds of viruses that that SARS-CoV-2 is a member of, and the sort of life cycle and pathogenicity. So, and then get into the studies that we've been conducting, both addressing blood safety considerations, but also using both the U.S. and the global blood supply as a resource to monitor the outbreak, and also work on convalescent plasma, which is a major focus of blood banks in the US and globally to help provide plasma from recovered patients to people who are either in early or advanced stages of illness. So just to orient people, again, this is a coronavirus, which is enveloped and gets its name from the electron microscopy spikes that look like a crown around the virus in the lower right here. They are fairly large viruses in terms of the viral genome, close to 30 kilobases, and they're very contagious. So these are, as a family, highly contagious, both common cold viruses and of course, the pathogenic coronaviruses, which include SARS-1, MERS, and now SARS-2. So there were 6 previously well-known common coronaviruses that circulate globally and recur, and people get infected annually with common cold viruses. And then, of course, we had the SARS-1 and then the MERS outbreaks that occurred over the past decade. These viruses bind to target cells through a receptor called the ACE angiotensin converting enzyme receptor 2 that are present not only on the pulmonary epithelium that result in the serious pneumonia, but in many other organs and tissues, including endothelial cells throughout the vascular system. So the viruses attach using the spike protein and through a modification of the spike protein when engaging the ACE2 receptor, a cleavage occurs with this TMPRSS2 protease on the surface of cells that allows the virus to gain entry into the target cells. And the virus causes disease both by direct cytotoxicity, by dysregulation of this angiotensin and aldosterone system, and then by multiple secondary methods of pathogenicity, including extensive inflammation, inducing a acute respiratory distress syndrome, and again, a systemic endothelial disease, which causes many manifestations in different organ systems, including coagulation and thrombosis, and then also a sort of cytokine storm phenomenon. And as people are seeing from the lay press and the literature, the initial focus on the pulmonary manifestations that are unfortunately fairly common and can be fatal have now grown into an appreciation that this is really a systemic infection and a systemic disease with neurological, renal, hepatic, GI, coagulation, cardiac, endocrine, and skin manifestations. So really has proven to be an incredibly challenging virus to both treat and prevent, and the disease manifestations much more diverse than originally expected. This is a profile of the laboratory parameters that we measure to track the infection in people. It emphasizes that what we now know well, which is that people become positive for the virus in their secretions, their oral secretions prior to symptom onset. So probably, close to half of transmission is occurring from people in either pre-symptomatic or asymptomatic infections. This shedding of virus begins about 1 week after exposure and peaks about a week later when symptoms onset occurs, with shedding into the nasopharyngeal fluids and transmission to other individuals. One area of great focus now is the utility, obviously, of not only PCR highly sensitive molecular tests, but alternative ways to detect early infection and infectivity using antigen tests or pooled sample swabs. And especially as the school openings are occurring, we're seeing widespread FDA approval and use of either pooled swab-based PCR technologies or antigen detection rapid tests to detect people who are infectious, recognizing that those methods aren't as sensitive as single sample PCR, but do detect the vast majority of people when they're infectious. Now, after the symptom onset, or in the context of an asymptomatic individual, the antibody and other immune responses kick in, and those initially are antibodies to IgA, IgM, IgG against various virus proteins, both the spike proteins, the nucleocapsid internal protein, and other proteins that we can detect based on antibody testing, which is generally applied to plasma samples or serum samples, but can also be applied to saliva samples to detect antibodies. Now, within the week or so of symptom onset and antibody and other cellular immune responses, the virus levels drop profoundly. But you can detect viral RNA in both oral secretions as well as actually in blood for several weeks after clearance of symptoms. But that persistent low-level virus shown here in the blue is not believed to be infectious. So the antibodies are able to neutralize the virus, and the viral loads are much lower than appear to be necessary to transmit. This review article, also recent, focuses on serological testing, and I'll go through many of the same points here, just emphasizing that serology has many different applications, and we'll talk about these and look at examples of these. And there's also testing algorithms that are described in this review article in Annals that appeared about a month ago that I'd recommend. So I want to speak a little bit about the studies that we're driving here at the Vitalant Research Institute that's partnered with UCSF. One of them is a longstanding program called the REDS program that actually began in the late 80s and is in the fourth phase of this REDS program. Each phase is about a 7 or 8 year period. And we've led this program from here at UCSF for that entire 3 decades. So this is the foundational research program that the NIH uses to respond to threats to the blood supply on a global basis. So when the SARS-CoV-2 outbreak was clearly becoming a serious problem in the US and internationally in January and February, we developed a program we call Response that has these aims outlined here that I'll walk through. The first was to really address the blood safety concern. Is the virus in the blood supply? The second is to use antibody testing to monitor for the outbreak, the proportion of the population that's been infected in different regions of the country by testing samples from healthy blood donors for antibodies, and we'll talk about that. The third is to actually track cases of donors who get sick after they donate. And we call this post-donation information reporting. And it happens all the time in seasonal profiles where people who donate blood and are healthy today can get ill in the subsequent few days. And then we're always asking them to let us know. And now we're testing samples from those donations for RNA and tracing recipients of those donors. So this is another approach to understand whether there is a transfusion risk of this virus. And then we're also in this study following 150 of these donors who were infected and found to be positive by either diagnosis after they donated or by detection of the virus in their samples of plasma from the donation. And we're following those people to characterize the evolution of immune responses and correlates of both control and protection from reinfection. So again, this program, the REDS program, is charged with addressing the blood safety threat, but it's important to emphasize that there's never been a transmission of a coronavirus by blood transfusion. So this is really an effort to evaluate the potential risk by applying very sensitive assays to see if the virus is in the blood of healthy donors, and again, to conduct these serosurveys on donor samples and understand the natural history by investigation of longitudinal samples. So this program launched on April 1st. And again, on the blood safety side, whenever we're faced with an emerging infectious disease threat, which unfortunately happens almost every year, we have to ask these three questions. Is the virus or pathogen, parasite, etc., in the blood supply? And that requires using sensitive assays to detect the virus in large numbers of blood samples from regions experiencing outbreaks. The second question is it transfusion transmitted? And that is addressed by doing what we call look-back studies, tracing recipients who got exposed to positive blood, but also doing animal transmission studies, which we do both in murine models, but most effectively in our close collaboration with colleagues at the UC Davis Primate Center. We've done many studies of transfusion transmission in macaques that have been really instrumental in defining the risk of transfusion and the correlates of transfusion transmission. And then lastly, even if agents are transmitted by transfusion, they need to cause disease. And there's a large number of commensal viruses that do not cause disease that we all harbor. Obviously, we have herpes viruses, but in the bloodstream, there are also a number of viruses at very high titer that are essentially normal flora, blood flora, and they don't cause disease. So we don't screen the blood supply for these agents. In the case of SARS-CoV-2, because this virus has evolved to be a respiratory pathogen entering the human through oral exposure, and then respiratory exposure, and then predominantly replicating in the respiratory tract, even if it is transmittable by an injection of blood from a transfusion, it may not cause pathology. So we need to understand that, and again, are doing those studies in animal models as well as through human follow-up studies. So in terms of the virus being in the blood supply, there have been reports of RNA-emia or viremia in the range of 1 to 15% of samples of blood plasma from clinically ill patients are positive for the virus. And there have been reports of the virus detected in asymptomatic blood donors. A recent paper in EID here, and there was also a study from Stanford Blood Bank that reported detection of an RNA-positive blood donation here in the Bay Area about a month ago. So to address this, we've been testing very large numbers of blood donations from regions of the country that experienced early outbreaks, places like New York City, Seattle, the Bay Area, LA, and we've taken advantage of the fact that whenever we screen blood donations, we create what we call mini pools, which are pools of typically 16 donation samples that are tested for HIV and hepatitis B and C and West Nile virus and Zika virus. So those mini pools are available, and we've been accessing those and collecting 3,000 mini pools from each site from each month. So we've been testing these for RNA using a very sensitive technology called the Grifols Panther NAT assay. And so we have tested now over 200,000 donations and only detected one very low level RNA positive sample that is being subjected to culture now, but it's extremely rare. So the answer with respect to the blood supply is it can rarely be present in blood, but it is at such low levels that we do not believe you can transmit this virus by transfusion. This next slide is the aim 3 of this response program, which is investigating these donors who call back after they donate and report COVID-19. And this happens all the time around the country when there's outbreaks. People are appropriately giving blood to help patients who need blood transfusions. There's active recruitment of individuals throughout the country and often shortages. So, but people who are healthy blood donors can get exposed and infected. Of course, we protect them to the extent possible through very safe practices at the blood collection facilities, but they do become infected and they do call back, and then we are able to capture the plasma from the donation and test it for RNA. You can see at the bottom here in the graph, this is the seasonality of the more traditional influenza outbreaks that occur every winter. And we're tracking these frequencies of these PDI reports and capturing them with a systematic program across the country in all of the largest blood collection organizations. So we're really monitoring about 70% of the blood supply for these post-donation information reports, and then we're enrolling those donors into follow-up. Now this slide, again, is it may have been published in the interim, but it was, as so many papers now, posted as a pre-review paper. But it's a very nice summary of the detection of SARS-CoV-2 RNA in blood donation or blood samples from a collaborative network in Oxford, where they reviewed the literature and had 28 studies that reported detection of RNA on average in about 10% of blood samples from clinical cases. But they also did a very nice study on 212 samples where they tested those samples for RNA and attempted to culture virus. And they could detect RNA in plasma in about 13% of the donors, but none of these samples were culture positive. And the RNA was predominantly detected in the early week or two following disease onset. So I'm going to change gears to the serology side of the challenge here from the molecular testing. So this slide, which is actually, there's an article, editorial commentary that includes this table and another table I'll show at the very end about serologic testing coming out in Clinical Infectious Diseases next week. But it makes the point that antibody tests to this virus have many different applications. One is as an adjunct to acute infection diagnosis. Again, because we know that people can be infected and have low levels of shedding or even asymptomatic infections, we need antibody tests in addition to molecular tests to confirm whether people were exposed and infected who might have had symptoms or high-risk exposures. We can also use these assays to monitor for exposures in highly exposed populations, such as healthcare workers, first responders, or as people go back, have re-entered the workforce, for example, or now back to school. You can test for antibody to identify people who have pre-existing antibodies and may be less at risk of reinfection or disease versus who are antibody negative and are still fully susceptible. A major role that we've used the antibody test for, and I'll describe, is the qualification of convalescent plasma and hyperimmune globulin. And these are passive immunotherapy strategies that have proven to be quite effective in other infectious diseases, things like Ebola, the original influenza types of pandemics, that by transfusing plasma from recovered individuals or creating a hyperimmune globulin therapy from recovered individuals' plasma, we can prevent and treat infection. Another major application is serosurveillance. So this is trying to determine what proportion of the population was exposed and had antibodies to the virus, either in targeted high-risk populations, such as healthcare workers, first responders, or regional, state, or national serosurveillance studies. And I'll talk a fair bit about large studies that we're driving. The durability of immunity is really the million-dollar question. As I'll show a little bit later, the antibody responses to this virus are not long-lasting. They wane over the course of 2 or 3 months. And so there's quite a bit of concern and research to address whether antibodies and cellular immune responses that develop following infection are resulting in protective immunity versus are people reinfected potentially again after they've cleared the infection and their immunity has waned. And you can actually use the antibody test to detect reinfections, because when you do get reinfected by a virus like SARS-CoV-2, the antibodies will boost. They'll wane, and then you'll see all of a sudden there'll be a several log increase in antibodies. And that's a way to document that people have been re-exposed and probably reinfected. And then as we see vaccines enter the SARS-CoV-2 clinical practice, we'll be needing to have antibody tests that can detect vaccine-induced seropositivity to confirm that the vaccine was effective at inducing antibodies. But we'll also need good tests to detect breakthrough infections, because these vaccines are unlikely to be 100% protective or sterilizing at first. So we'll use antibody tests to detect breakthrough infections by detecting antibodies to proteins like the nucleocapsid proteins that are not present in the vaccines. And the vaccines, again, are all based on spike-based antibodies that neutralize the virus. And then finally, we're seeing large-scale screening of blood donors, both as an incentive to recruit donors, but also to capture seropositive people to donate convalescent plasma. And just to point out that these different applications require and benefit from a battery of different tests that can include point-of-care assays that give results back to people immediately, like pregnancy tests, although those tests tend to not be as sensitive or specific, versus lab-based tests. The antigen included in the assay ranges from nucleocapsid to spike currently, and different configurations of spike proteins. We also have various confirmatory assays, including microarray technologies, and then assays that can detect and quantify the neutralization potency of the antibodies, both to inform whether a person may be protected from infection, but also to guide selection of convalescent plasma for transfusion into patients. So moving back to the response program, that program included a study that launched back in March, where we captured samples, 1,000 samples from routine donations in 6 cities around the country, the same cities for whom we were doing the molecular surveillance for the virus itself. And we tested those samples with a very sensitive and specific antibody test. It's a test manufactured by Ortho Diagnostics that targets the spike protein of SARS-CoV-2. And this test, I'll show some detail on that. And then we confirm those infections using various other assays that I'll touch on. So this is the Ortho test that we're employing. It was the first test to receive FDA emergency use authorization. And it's a test that's designed to detect any antibodies present against SARS-CoV-2, whether they be IgM, IgA, or IgG, with very high sensitivity using what we call the antigen sandwich 3rd generation format. And this allows for very sensitive detection and very specific detection of any of the antibodies, in this case targeting the spike S1 domain of the virus. And these platforms, which we have several of here in the Blood Center in San Francisco, but we have hundreds of them around the country in many of our blood organizations, are very high throughput, so they can test many thousands of samples per day. Very specific, so the negatives tend to run very low, well below the cutoff, several logs below the cutoff. And people are positive for these antibodies generally within 8 days of symptom onset. So these rare cases that were negative were people who were negative also by neutralizing antibodies and were in the acute stage of infection prior to seroconversion. This is another assay. This is actually data Charles Chu and Diana Ng at UCSF led this study looking at the Abbott assay, looking at timing of seroconversion on longitudinal samples, seeing that simultaneous with IgG reactivity coming up, neutralizing antibodies come up. This is data generated by Graham Simmons at my institute using a pseudovirus assay. So similar to the ortho assay, within several weeks of onset of illness, virtually 100% of people develop these antibodies. This is an example of a neutralization assay. This is a pseudovirus reporter virus particle neutralization test that we perform at VRI that uses a construct. So rather than using live virus, which has to be used in biosafety level 3 facilities and has low input to do what's called plaque reduction neutralization, we generate pseudoviruses that express high density of the spike protein on the surface of a virus that's got a vesicular stomatitis virus backbone. So this virus is able to attach to target cells which are engineered to overexpress the ACE2 receptor and the TMPRSS2 protease. And then when those cells get infected, they emit a luciferase signal. So by adding a patient's serum to these pseudoviruses, you can block entry into these target cells and quantify that by doing dilutional titers of the patient samples. And this test has worked very well on many other viruses, and these are examples of neutralization titers from actual patients or convalescent patients. We also collaborate closely with Phil Felgner's lab group at UC Irvine that's developed a multiple acute respiratory virus protein array technology. And this technology includes now 12 antigens from SARS-CoV-2, the original SARS-CoV-1, MERS, and then all the common coronaviruses, influenza, adeno, etc. And you can essentially map the antibody reactivity of either infected people, shown in red here, across the SARS-2 proteome, or cross-reactivity to the nuclear proteins in SARS-1 and MERS. But at the same time, you can quantify antibodies to all of these other respiratory pathogens. And this becomes important to, one, prove the specificity of screening tests, but also to look at whether when you get infected with SARS-2, do prior memory responses to other coronaviruses result in increased disease. And this has been a concern, something, for example, with dengue, we know that's a serious problem with antibody-dependent enhancement. But in this example, we see a person infected with SARS-CoV-2 seroconverting to antibodies against SARS-2 and some cross-reactivity to SARS-1 and MERS, but no boosting of antibodies to other historical coronaviruses. So this is a tool that we use in our studies. Now, this is data that is showing the results of this serosurveillance testing in these 6 cities over the course of 3 to 4 months. Probably the most glaring example is obviously New York City, which had a very large outbreak that was predominantly in March and April of 2020. And you can see that the antibody rates increased as the outbreak occurred and then stabilized to about 12%. And almost all of these samples confirmed with both Roche nucleocapsid and neutralization. In the San Francisco Bay Area, we had about a 1% seroprevalence rate that stabilized, and we're now testing July and August samples from these 6 cities, as well as many others, as I'll describe in a moment. But this illustrates how we can use routine blood donation samples to track these outbreaks by applying antibody testing, screening, and confirmatory testing to large numbers of healthy blood donor specimens. Now, the CDC has expanded this program through a national SARS-CoV-2 seroincidence study that is funded, which includes a series of studies. The first aim is to actually validate different assays for serosurveillance. So we have constructed a panel of 1,000 samples that include convalescent samples from SARS-CoV-2 antibody-positive individuals, seroconversion panels, longitudinal samples from convalescent plasma donors to look at durability of antibody reactivity, and then pre-COVID samples, so samples of plasma collected last year that have been characterized for antibodies against a variety of other pathogens as specificity controls. So these are now being tested on multiple high throughput platforms to demonstrate which of these assays are the best assays to use for serosurveillance. The original funding, which kicked in May, expanded the study to 25 regions from the original 6 regions, with testing over 12 months and then again at 18 months. But as I'll show in a moment, the study has since exploded in terms of the scale of this study. The study is also enrolling and following 150 of these convalescent plasma donors for 18 months to characterize the persistence of immune responses, both humoral and cellular immunity. And these are the assays that we're evaluating. I'm not going to go into this, but it's fortunate that we now have excellent high quality commercial manufacturers building antibody tests that target these different antigens, which will be critical as we see vaccines come into the field. And they have different formats in terms of the design of these assays. So these assays are really all excellent, but which ones are the best for serosurveillance is what this study is designed to pursue. So as I mentioned, beginning in July, we expanded the study to an additional large number of regions. So we added 19 additional metropolitan regions. And the study initially started in July with 1,000 samples per month. But over the last several months, the CDC has expanded the program. It now includes 60 US metropolitan regions and states. It includes all 50 states. It includes Hawaii and Puerto Rico. So really a very large study covering the entire United States, and really quite an undertaking that, our team here in collaboration with large numbers of other blood collection and testing labs are pursuing. We're not the first to do this. We've done these kinds of serosurveillance studies over the many decades, but in terms of SARS-CoV-2, close colleagues in Denmark and the Netherlands have recently reported the application of antibody testing to measure the rates of infection in their countries. So in this case, in the Netherlands, they documented a substantial rate of antibody positivity in the southern region where they had some large festivals when the outbreak was first occurring. But overall, only about a 4% antibody positivity rate. In the Danish study, they similarly estimated about a 3% antibody positivity rate using blood donors. And then by taking the donor data in terms of the demographics, the age, other factors, you can estimate at the population level how many people became infected. So the Danish study estimated that by the time they did this study in May, that about 66,000 Danish citizens had been infected. And they estimated about 21 infections occurred per diagnosed case, and that about 82 per 100,000 infected people died of the infection. So by doing these large serosurveillance studies on blood donors, we can capture the overall proportion of the population infected and estimate the infection to fatality ratios. This is similar data coming from England National Blood Service. And they're showing rates across the country as high as 15% in London. So just illustrating that you can get fairly high rates in focal dense population centers such as New York. And I've seen data from, for example, Sao Paulo and other countries where the donor data is showing even as high as 50% antibody positivity rates in some focal regions. And these obviously change over time. I just wanted to show a couple slides to emphasize points I've alluded to, which is that the immune responses to these coronaviruses wane. They're not long lasting. In this example published several decades ago, they purposely infected volunteers with common cold coronaviruses and quantified the antibody responses, both the IgG levels as well as the neutralizing titers. And you can see within 2 to 3 weeks of infection, the antibodies began to come down, and by a year later, the antibodies were essentially back at baseline. And when they re-challenged these people a year later, they seroconverted again and shed the virus again. They were infected with the exact same virus again a year after they had been infected previously. So this is the concern with SARS-CoV-2, is will prior infection induce a persistent immunity to reinfection? And will vaccines be able to induce an immunity that's durable and protective from infection? And as the last few months have evolved, we've begun to see a number of papers that are showing that antibodies to SARS-CoV-2, just like the common coronaviruses, wane after only 1 to 2 months. And if you have an asymptomatic infection, people tend to have lower levels of antibodies and more rapid waning to negativity. So this is a serious concern that we're studying carefully. This is a recent paper published in New England Journal showing the antibodies waning over the course of 2 to 3 months. And we're working closely with the LINK study, Michael Peluso and Steve Deeks and others here at UCSF that have enrolled a large number of people into longitudinal follow-up and are seeing similar waning of antibodies with different assays over the course of just 1 to 2 months of follow-up. So just to conclude, I want to talk about convalescent plasma and hyperimmune globulin, and particularly convalescent plasma, because that is a current active therapeutic that's being highly publicized. President Trump had a big conference about it a few weeks ago, and it's really scaling up and being issued to lots of patients around the country now. So with that in mind, our company has collected, literally tens of thousands of these units, and through our program at UC in Denver, we are doing a number of studies to characterize the persistence and neutralizing potency of antibodies, and to identify assays that can qualify units for rapid release as convalescent plasma. If you look at donors who recovered from illness and come in to donate convalescent plasma with an antibody test, a very sensitive antibody test, one of the surprising findings that's now being confirmed by many groups is that about 5% of people who were infected do not develop antibodies. And this is something that we call serosilent infections, probably related, mostly seen with very mild infections, and related to an infection that's controlled in the upper respiratory tract before it becomes systemic. And a key question is whether people who don't seroconvert, whether they have any cellular immunity and have any protection from reinfection. But the majority of people who are infected do have antibodies of variable intensity. And when we look at the durability of those antibodies, they're really quite durable with the tests that we use to screen the donors and for our serosurveillance studies. So these are longitudinal weekly collections of convalescent plasma from about 850 donors. And you can see that these lines are really quite stable. But these samples are now being tested with a number of other antibody tests that we expect to show waning, including neutralizing antibodies. So this becomes another example where the blood donor population, because we're collecting serial convalescent plasma units, allows us to capture samples to characterize durability of immunity. We've also correlated the antibody intensity of the screening assay with the neutralizing potency, and they do correlate with each other. And then we can make algorithms that say, okay, if you have a reactivity on the antibody test, a single to cutoff reactivity of 10 or 20, that you would have this probability of having a neutralizing titer above some specific threshold. And we're working closely with the FDA and many other scientists around the country to determine what neutralizing titer is needed as a therapeutic dose of antibodies when we transfuse these units into clinical patients. And the general approach is that if the units are negative, these serosilent infections, we don't issue them as convalescent plasma, we issue them as routine, fresh frozen plasma. If the samples have a high single to cutoff ratio, for example, above 30, we have high confidence they'll have high neutralization titers and can immediately release them for transfusion. If they fall in this middle range with lower level reactivity on the screening test, then we subject them to neutralization testing and qualify the samples if they have adequate neutralizing doses. And then just a last slide to point out that critically important are these follow-up studies. I mentioned the LINK follow-up study here at UCSF, and then we have 2 large follow-up studies supported to capture both cellular material and plasma from the blood and nasal swabs from people to really understand the dynamics of immune persistence and the correlates of protection from reinfection, but also to understand the immune response to natural infection to guide the design and development of vaccines and evaluation of vaccines. So just the last slide, just to mention that although antibody testing is now widely available, and again, you can go to the blood bank and actually get a free antibody test, or through public health labs get tested for antibodies, they have limitations. So there is low rates of false positivity. This was particularly a problem for the early studies that were being published, for example, from Santa Clara, that were using point of care rapid tests that had false positive results at significant rates. But we always have to be careful, and therefore we always perform confirmation testing. You should not rely on antibody tests to detect acute infection. So this is why most of the focus on bringing people back to schools or sporting events, et cetera, are using molecular tests to detect active shedding of virus, because the antibody tests will remain positive for months and not indicate infectivity, and they take several weeks to seroconvert. So antibody tests are really not the primary test to use to diagnose acute symptomatic disease or to detect people who are infectious to other people. There is heterogeneity in the antibody responses. So we are characterizing that and understanding its relationship to both past exposure to other respiratory viruses and the correlates with the symptom magnitude, which in general, the more severe the illness, the higher the antibody levels and the more durable. So it's kind of goes against your simple thinking, which might be that the people who get really sick didn't develop a good immunity. It's kind of the opposite. The people who got really sick had a lot of virus growing in them, and the immune system sensed that and developed antibodies. Again, we don't currently have a good understanding on what the antibodies mean with respect to protective immunity, either at the individual level or at the population level, what's called herd immunity. And clearly in places like San Francisco, where we only have 2 or 3% antibody positivity, we're nowhere near the 50% or more of people who would need to be infected to create an immune population that would reduce transmission of the virus. We also, again, don't know that these antibodies and the cellular responses wane over time. So we may need to boost immunity in both naturally infected and vaccinated people. So this is not a virus that a single shot of a vaccine or a one-time infection can be inferred to result in lifetime sterilizing immunity. And then vaccines will really, obviously are going to be critical, and the early data is looking very promising that these both RNA and antigen vaccines are able to induce very high levels of antibodies and potent neutralizing antibodies. But they do then require new tests that can detect and discriminate the vaccine-induced antibody responses from infections that occur in vaccinated people. So we're working closely with companies to bring up assays that can discriminate this VISP, vaccine-induced seropositivity, from natural infection and reinfection. And then just a final point, which is that the virus, like HIV and hepatitis, is spreading all over the world, as we all know, and there are mutations that have been identified that can either reduce or increase the infectivity and potentially the pathogenicity, the probability of disease outcome. Fortunately, these don't seem to be mutations that are driven by immune response selection. So they're not evolving in the same way as HIV did to evade the immune system, and the virus does not establish a persistent chronic infection. And then finally, although we're studying it and making sure, at this point, there's no evidence that the mutations that are being observed in the virus impact the sensitivity of serological or molecular assays. So with that, I'll stop and be happy to answer questions.
Thank you so much, Mike. This is one of the most fascinating and informative webinars of the very many I have attended. I do have many questions myself. I don't want to monopolize the microphone. I know the audience also has questions, but if I may, let me get started with a couple. So you have mentioned that national seroprevalence studies range from 2–3% in San Francisco, 20% New York City, and maybe 50% in Sao Paulo. So what does it mean in terms of herd immunity? This is something that people keep asking. What is the threshold to achieve herd immunity? And given the seroprevalences we've seen in some places, maybe we're getting closer to that.
Yeah, Jaime, there's a beautiful paper in development by Esther Sabino, our good colleague from Sao Paulo, who runs the network of hemo centers in Brazil that's part of our Chagas studies in the past and still active under the REDS program. And the data from Manaus is really fascinating. In Manaus, near the head of the Amazon, they could not curtail the outbreak. These are impoverished people living in dense populations. So they actually had a very large outbreak, huge death rates. It peaked back in April and May and then began to fall dramatically. And when Esther tested blood donor samples from Manaus, she observed that 60% of the donor population seroconverted shortly after the peak of the clinical case and fatality outbreaks. So we do believe the hypothesis there is that they did achieve herd immunity, that enough of the population seroconverted at that 60% rate that transmission of the virus essentially was curtailed in the absence of mitigation strategies such as we're used to here. So this is the first data I've seen, empiric data, if you will, that demonstrates that an outbreak was essentially aborted by virtue of the scope of spread within an at-risk population. And this is probably occurring, in many underdeveloped countries in Africa and Asia, India, where high density populations are unable to protect themselves from infection. In a sense, fortunately, many of those populations are younger age individuals. So although people have certainly died, they're relatively less susceptible to severe outcomes if infected. But unfortunately, we're very far away from that 50–60% seropositivity, and really vaccines are the only hope for establishing sufficient immunity to prevent continued spread and reintroduction.
Please allow me two quick questions more before I let Colin also bring some from the audience. So one is dosing of infection seems to be correlated with severity. Is it also correlated with antibody titers, as far as you know?
Yeah, I know there's some recent work to your first point, which, generally for infectious agents, the inoculum dose isn't a major determinant of severity. If you get infected, it's really your own host's ability to control that infection and the manifestations of the infection, such as ARDS, which we're talking about here, are often immune-mediated damage. So, but as you stated, there is certainly some recent work suggesting that the dose acquired, inoculum, does correlate with severity, and there's a large amount of data that the severity of clinical manifestations correlates with the intensity of the immune response. So that's clear. Now, whether and again, I think it's likely that the immune response triggered by a high dose virus trying to control viral replication is partly mediating the clinical severity, because the antibodies are binding to the infected cells and inducing a cytokine storm response. So it's a little bit of a vicious circle with a immune response being necessary to control the infection, but also contributing to the disease manifestations. But again, in terms of, for example, recruiting people to donate convalescent plasma, what we've learned is that the people who were relatively sicker, hospitalized, or had at least clinical manifestations have significantly higher levels of antibodies, including neutralizing antibodies, than completely asymptomatic donors who we pick up through large-scale screening.
And that's my next question, precisely on convalescent plasma. Sounds very promising, but I haven't seen randomized control trials for obvious reasons. So in your view, what is the usefulness and what is the scalability of this potential therapy?
Well, there's a paper that was just posted, I think, Monday of this week from the Mayo Clinic, Michael Joyner's group, that's a national effort to compile data on transfusions of convalescent plasma. So this was the first 3 months of this large national open IND trial. I forget the exact number, but it's in the range of 10,000 transfusions of convalescent plasma. And they do demonstrate that it's an uncontrolled study, observational, but they do demonstrate that the earlier patients were infused with the plasma during their disease course, and the higher the titers of antibody reactivity, the lower the mortality. So this is, there have been several small randomized trials that showed, for example, from China, that if you infuse plasma late in the course when people are already ventilated, for example, you don't see any benefit. There are a fairly large number, at least 30 randomized trials in progress now around the world, including several funded by NIH. Those trials are selecting plasma from donors who recovered from clinical illness and have high titers of neutralizing antibodies. So they're sort of pushing the envelope toward maximal evidence of efficacy. We need those trials data to confirm that this is efficacious and to inform. Many of them are now focused on people just as they come into the emergency room. So we're infusing the plasma early in the course, which is probably more effective before the person has formed their own endogenous neutralizing antibodies. In terms of scalability, it's been incredible how many people have come forward to donate convalescent plasma, how the National Blood Collection Organization in the US and really globally has come forward to collect huge numbers of units, and the government has really come forward through BARDA funding to support the collection of those units. So this is going on in the thousands every day now, and so it's really been a success story, but it will be supplanted probably by hyperimmune globulin, monoclonal antibodies, and then vaccines.
Colin, I know you have a question from the audience. Do you want to go ahead now?
Thank you, Jaime. Mike, thanks very much for that excellent presentation. We do have a couple of questions from the audience, some of which go back to more basic things about blood banking in general. I'm wondering if you've noticed in your seroprevalence surveys any differences in the donor community based on age, demographic, blood type, or any other factors that might suggest that one has to make adjustments when projecting to the broader population.
Yeah, we do have data now both from our studies that are focused in these regions and sampling studies, but also with the introduction of universal antibody testing beginning back in May and June in order to encourage people to donate blood and to find convalescent plasma. There are really huge data sets now in the large blood organizations, and they're all showing sort of not surprising findings in terms of significantly higher infection rates in younger people, particularly over the last month or two as people have come back out and been exposed. Significantly higher infection rates in racial ethnic minority populations, quite variable rates around the country. In terms of blood group, there's controversial suggestive data that the ABO blood group does have some association with disease outcome, but no evidence of any association with seroprevalence rates, so infection rates. So, but this is all tracking. So we're doing this. Fortunately, we're funded to do this every month on an ongoing basis for the next year and a half. And the CDC has just continued to identify additional resources to expand and sustain and make this all real-time posted. So literally over the next 1 to 2 months, you'll be able to go to the CDC website and see the data from the national donor serosurveillance from the previous month, and plots of how the antibody rates have changed over time, and correlations between antibody prevalence and mitigation policies.
Great. So with all of those adjustments, you can kind of project. Has donation rates gone down? Have they changed at all in the aftermath of the pandemic?
Yeah, I mean, it's been a huge impact on the blood supply, partly due to the early, again, shelter-in-place policies, the cancellation of schools. So a lot of blood was collected in work and school environments that were completely stopped. Hospitals also stopped doing elective surgeries that needed a lot of blood. So we've been struggling to maintain a balance of blood collections with hospital needs. One of the things, again, that was done to encourage people to donate was to offer the antibody test. And I wasn't a big proponent of that. We've always been concerned about test seeking, encouraging people to donate blood and not necessarily being fully honest about their exposures. And indeed, when we look at the antibody rates to SARS-CoV-2 donors, they're about 2 times higher than in repeat donors. And that's telling us that people are coming in to get tested. And that's fine, and it's been successful at bringing a lot of people in, but it actually biases the serosurveillance data. So we have to figure out how to account for that when we analyze the data, because by having people come in who are at higher risk, we get higher rates of antibody than reflective of the true general population.
Right, but you make those adjustments. I'm wondering if you have a top-line number in mind that you would sort of reflect as the rate of infection in the U.S. based on the studies you've seen so far.
Oh, wow. Yeah, I mean, the data, obviously with the recent resurgence of the outbreaks around the country, I've seen data, for example, from Florida, that is Florida statewide, the antibody rates in the donors are in the 12-13% range, with focal regions that are achieving 20%. I think in general throughout the country, we're probably in the 7 to 8% antibody rates across the country, but it's so regional. And we're now doing studies in Des Moines, Iowa, for example, where the meat packing plants are, and in Houston and Dallas, et cetera. So this is going to be a constantly evolving outbreak. And again, we have to account for that waning of antibodies when we do these serial cross-sectional serosurveys. So we need that longitudinal data. We need to choose tests that are not susceptible to waning in order to have an accurate cumulative estimate of infection rates.
Thank you. Jaime?
We probably need to have a time check here. Mike, I could go on and on. Hopefully I can send you some of the remaining questions I had offline. Again, this has been a truly informative session of questions that a lot of people have. This is just a reminder that this session has been recorded and is going to be posted in YouTube later today. So it will be seen by a multiple factor of the people in the audience right now. A quick reminder, our next COVID series will be not next week, but 2 weeks from now, September 1st. The speaker will be Dr. Mary Wilson, and we will be covering the controversial issue of droplets, aerosols, and transmission routes. So please stay with us. Mike, thank you so very much for a splendid session, and look forward to have you as a speaker in a few weeks when you have results from your very fascinating studies.
Great. Good to see you, Colin and Jaime.
Good,
Thank you all. Goodbye.
Bye.
Thank you.